Hi, everyone. Welcome in. We're going to wait a moment or two to get started, but we're very glad that you're here. If you want to introduce yourself in the chat, feel free. Always nice to know where folks are coming from. Like I said, we'll get started in just a moment to let some more folks come in. And yes, we have some great staff in the chat going to give lots of reminders. This session is being recorded. We will make it available to everyone who registered along with the slides. You'll get lots of details in your email. So again, we'll have folks kind of trickle in. Feel free to introduce yourselves. But just for the sake of time, we have a packed agenda today. So we will go ahead and get started. So hello and welcome. This webinar is focused on expanding health center services to an aging population through PACE. So today, we're hosting this webinar from the National Center for Equitable Care for Elders. My name is Ariel, and I'm the program manager of our center. If you are not familiar with us, we are a training and technical service provider housed within the Harvard School of Dental Medicine, providing learning opportunities for health centers and other community-based organizations around the health and well-being of older adults. We'd love for you to stay connected with us. We have all of our social media links there, and you'll certainly be connecting with us via email for all the follow-up details from this session. I always like to promote the Clearinghouse in any learning opportunity that we have because it's such a great one-stop shop for resources geared towards health centers. So lots of up-to-date COVID-19 information, along with lots of other topics that are relevant for the care, not just of older adults, but lots of patient populations. So we have that linked in the slide. Many of us are very used to Zoom learning opportunities at this point, but just a few reminders to keep us on the same page. All lines are muted, but we really would love to hear from you, whether that's in the chat box or the Q&A. We're going to be hearing from several speakers today. So if you have questions or you'd like to share, please do utilize one of those features. We'd love to hear what you have to say. Again, this session is being recorded, and we will make that recording available along with the slides as soon as possible. And when you close out of this session today, you will get a little evaluation survey pop up. We'd love to hear your feedback. Take a moment, let us know what you think. That's going to help improve our future training opportunities. Thanks so much to folks introducing themselves in the chat. So you signed up for this webinar, so you have seen these learning objectives, but our focus today is really on understanding the benefits of the PACE model of care for community dwelling older adults. We're going to really be able to dive into an example of this type of service within a health center setting, be able to identify some best practices. We're not going to dive too deeply into the application process or the implementation process, but we do hope to leave you with some resources if you'd like to explore this as a next step for your health center or organization. So very quickly, we do want to begin with some level setting on the increasing relevance of providing quality and inclusive care to older adults. You can see in this slide, we've linked to the very latest profile of older Americans from the Administration for Community Living, but we do see that the older adult population is growing. Individuals over the age of 65 represented about 17% of the population in 2020, but they're expected to grow to be 22% of the population by the year 2040. You can see those last two bars there are projected numbers for 2040 and 2060. The growth of older adults in the general population is, of course, also reflected in the age groups served in community health centers over the last decade. You can see from this community chart book from NAC that patients over the age of 65 more than doubled being served in health centers between 2010 and 2020. We'll undoubtedly continue to see an increase in that direction, which makes conversations about programs and services that enable this population to age in place safely in their communities of choice more important now than ever before. So one option that can assist in this effort is PACE. So that's our focus today, programs of all-inclusive care. for the elderly. So this model of care aims to provide a comprehensive list of services, not just medical, but also social, overall wellness to older adults who are both frail and community dwelling. So typically these are folks who are duly eligible for Medicare and Medicaid. If they're enrolling in a PACE program, that becomes their singular healthcare coverage program. These services are designed to allow patients to remain in their communities instead of receiving the care they need in a nursing home. So you'll see the basic eligibility requirements on the screen is going to be different based on state and service area. If there's additional requirements, but you can see that it's a lower age than is typically used when we're talking about older adults, but it accounts for those who are living with some complex care needs as they age. I especially want to highlight that we have a requirement of living in a service area for PACE. So again, we're highlighting a program example today, less focus on the CMS application process, special considerations for this type of program development, but we will include some resources if you are interested in taking it a step further and researching that for your own institution or area. So before we get into those resources, I did want to expand a little on this concept of frailty because it can kind of be a pretty vague concept, especially when we're thinking about it in the context of community dwelling older adults. So it's important to note that this type of decline is related to age, but it does not mean that all older patients will experience this. You'll see that frailty can present as a loss of things like muscle or stamina, dealing with the complexities of multiple chronic conditions, and maybe even the social component of absence of proper social network support. But the physical and emotional state is connected to an increased risk of negative health outcomes. So the best course of treatment for that is really a well-trained interdisciplinary team that can provide the most appropriate age-friendly healthcare, and we really get to see a fantastic example of that today. Which leads us to the approach of health centers specifically adopting this model of care. PACE is really well aligned with the mission of health centers, so to deliver that comprehensive, culturally competent, high quality primary healthcare services to the nation's most vulnerable individuals and families. So with those goals in mind, health centers in several states have pursued this type of programming, including California, North Carolina. We'll hear from a Massachusetts-based health center today. I have a link on this slide for a collaborative program that's specifically focused on that PACE Health Center connection. It's a partnership between Capital Link, the Galway Group, the National PACE Association, and the National Association of Community Health Centers, and we'll hear from NAC a little later today as well. But the general link is on this slide. I do have two specific resources from PACE at CHCs I did want to highlight. The text is very small, but you can see that there's two links, one for a self-assessment toolkit and then related guidance. This is going to be a great resource for those who want to dive in a little deeper through areas like, understanding demand for services in your area, organizational structure and capacity needed for this type of work, and then organizational commitment as well. So encourage you to look at those resources. And then some more general National PACE Association resources. Certainly their general website has a ton of great information. There's a link around starting a PACE program, lots of FAQs there. Also includes on this slide their effort to further PACE expansion across the country. There's a map on their site where you can really see it's not in every state yet. There's a lot of areas of the country that don't have a lot of representation here yet. And then there's a fantastic issue brief at the bottom of this screen around age-friendly health systems and PACE. The age-friendly health systems framework, the 4 M's, we use a lot in our center when we're talking about what matters to older adults. This framework was developed and now championed by the John A. Hartford Foundation and the Institute for Healthcare Improvement. So that's just a little level setting. Again, lots of resources you can take a look at if you want to go back after you receive the slides, but I want to give the most time we can today to really dive into a fantastic example of PACE at a health center. We have two wonderful guest speakers with us. I have their bios, so I'm going to take a moment to read both of them, and then I'm going to pass it over to their team. So both of these individuals are from Neighborhood PACE, which is a program of the East Boston Neighborhood Health Center, where our center is as well in Massachusetts. So Andreina Sanaria is the Assistant Vice President at Neighborhood PACE. She is originally from Venezuela and is a serial entrepreneur with more than 15 years of international experience in the healthcare industry, including South America, the English Caribbean, and the US. She was the co-founder and managing director of the first medical call center in Venezuela, with more than 700,000 lives associated to the program, and served as the executive director of NGO Fundación Proyecto Manipur, an NGO recognized by the Schwab Foundation of the World Economic Forum that delivers primary care and telehealth to underserved and remote indigenous and Creole communities in Venezuela. After moving to the US in 2015, Andreina's experience has continued to focus in pursuing her mission of helping underserved communities, working closely with FQHCs. She's been engaged in different capacities with the East Boston Neighborhood Health Center since 2019 and is now the Assistant VP of the Neighborhood PACE, overseeing health plan operations, quality, and business development. She has a bachelor's degree in business administration from Universidad Metropolitana in Caracas and a master's of healthcare administration from Boston College. We are also joined by Dr. Jim Padula, who's the medical director of Neighborhood PACE, which is one of the first 4 PACE programs established in the US expansion of the Unlock model in June 1990. He's been with Neighborhood PACE since its inception, having first served as one of its original primary care providers and for over 25 years as medical director. He received his MD degree at Northwestern University Medical School in Chicago in 1984, and then completed a residency in internal medicine at the former Boston City Hospital in Boston in 1987. He received his certification for added qualifications in geriatrics in 1992. He's been involved in the development of PACE for over 32 years as a member of the National PACE Association Medical Leadership Committee and as a participant in advisory board panels for NPA initiatives. For the past 2 years, he's chaired the NPA Medical Leadership Committee and was a member of the NPA Board of Directors. He now serves as immediate past chair of the NPA Medical Leadership Committee. So you can really see from those bios, these are two very well-suited folks to talk about this fantastic programming. So I'm going to go ahead and go on mute and turn it over to our two wonderful guest speakers.
Thank you, Ariel. And thank you everyone for being here. My name is Andreina Sanaria. Thank you for introducing me. I'm the Assistant Vice President of Neighborhood PACE from East Boston Neighborhood Health Center in Massachusetts. So I am going to share with all of you a little bit about East Boston Neighborhood Health Center. Then I'll pass it over to Jim, who's going to talk about the features and benefits of the PACE program. And then I'm going to talk a little bit about the growth and special projects that we have in Neighborhood PACE. We can go to the next slide. Thank you. Yeah. So this is our mission and core values. We have recently launched our 2025 goals and a strategic plan, and is based around these core values and mission at EBNHC. We are actually the largest health center in Massachusetts. We're located in northwest of Boston area. And we have been serving the community for all this time. And we're very proud of being serving for more with our ED for 24/7, which is something that is very novel in a community health center. If you want to go to the next slide. So we serve, we're the major provider of care in community health centers. And you can see here a little bit of our serving area where we are currently served. We have around 120,000 patients across all of our program and services. We have been receiving over 400,000 visits per year, and we have over 1,500 employees right now. Our community is very diverse and low income. We have about 71% below the 200 federal poverty level. 70% of our community that we serve speaks other language than English. The majority, I have to say that it's Latinx community. People is very isolated geographically, and we have a market penetration rate of in the following cities, from East Boston around 73%, Chelsea 37%, Revere 29%, Winthrop 27%, and Everett 11%. If you want to go to the next slide. Okay. So what I'm sharing here is a little bit about those strategic goals that we have for 2025. They are all around clinical quality. We want to be able to serve our communities, in the best possible quality care for them. For one company and one experience, that means that we want to engage our very committed workforce in moving forward the care for our patients. We are very proud to say that we have been recently named for the 8th time one of the top places to work in Boston by the Boston Globe. We have also been focusing on our growth, and then you can see in the slide there that neighborhood PACE is one of the most important services as part of our growth in East Boston Neighborhood Health Center. And then the operational excellence is also one of our strategic goals, and we want to leverage all of our systems and our processes in place in order to be able to deliver better patient care and center patient care. If you want to go to the next slide. So at EBNHC, we deliver, first of all, our mission is around primary care. We have adult medicine, we have family medicine, we have pediatrics. We also have women's health, OBGYN. We have integrated behavioral health, we have dental. As I said earlier, we have a 24/7 emergency department, which is very unique in a FQAC setting. I have highlighted here our PACE program, which is a part of the program and services that we deliver that we're going to expand later today in the presentation and what the goal is for this presentation here. We have HIV services, addiction services, interpreter services, as the large population that we serve has, as I said earlier, don't speak English as a first language, then, it's an important service that we have and that we run very well. We have a lab, pharmacy, radiology, specialties, vision, nutrition, and we have been very focused on COVID care since the pandemic started. So talking a little bit about neighborhood PACE, our motto, I would say, is keeping adults 55 healthy and independent. It's been, if you want to go to the next slide, it's part of, as explained before earlier in this presentation, the program All Inclusive for the Elderly PACE is a national model that is care based upon the belief that the older adults would like to receive comprehensive care in their home and aging place with all an inclusive plan that just can do that. So it's very important, and we know how aging can be impacted by having our elderly living in their community. So that's really the goal that we're trying to pursue with the PACE program. This is a program that was originated on the West Coast over 40 years ago. Our program at EBNHC started in 1990. Currently, we have in Massachusetts over 8 programs, but across the country we have more than 6 programs, 100 programs in 25 plus states. And as mentioned earlier also by Ariel, There is a lot of opportunity to grow PACE in the country. The penetration rate is not as where we want it to be, so we welcome, new opportunities to grow the program with other organizations as well. In this case, for PACE, which is very interesting, and I believe is one of the, even though it's a program that has been over 40 years in the U.S. delivery system, the interesting part is that it's an insurance and a provider. We work under a capitated model for our participants, which is value-based care, where the health center, the healthcare delivery system is going towards in the United States. So it's very novel in that sense. It operates under CMS regulations and provides all services covered by Medicare and Mass Health, which is a state agency for Medicaid in Massachusetts. And every service is authorized by what we call an IDT, or the interdisciplinary team, which is focused on the individual and its goal for living independently and aging well in the community. Jim will take over later and explain a little bit about what the IDT team does and how it works. It's coordinated care from end to end based on this multidisciplinary team. And in enrolling in PACE, participants, one of the things that is important to say is that providers from PACE are the ones that provide healthcare, primary care to the PACE participants. Participants do not are currently allowed to continue working with their primary care physicians. They need to be PACE providers. I put there, one testimony of one of our participants, and we have heard a lot of those in the program. I have to say that when I got first into this role, which was less than a year ago, well, I heard across the health center a lot of our employees saying how we took care of their parents and their beloved ones in being in the program. So that was, it's always very encouraging to hear how we can impact the health of the elderly communities around us. I'm going to go to the next slide. Okay, so here is a little map and a little information about what we have at Neighborhood PACE in terms of centers and alternative care sites, or ACS. So everybody knows an alternative care site setting. I mean, it's a place where a participant receives care as well, but it is not as complete as a PACE center. It doesn't have all the services that are given in a PACE center. Currently at Neighborhood PACE, we have 3 different PACE locations, one in Lewis Mall in East Boston, another one in Revere, another one in Winthrop in Massachusetts. We recently opened an ACS in Everett to be able to dip our services in the surrounding areas of Everett, Malden, Medford, Stoneham, or a little bit on the northwest of Boston. We will have coming soon another ACS in Addison, which is in East Boston as well. And we have a wellness center in Winthrop that it's very well visited by our participants, where they have activities and they really enjoy going over there. So if you want to go to the next slide. We have, in terms of staff members, approximately 260, and participants, as based on the census from last month, were 788, continue to grow. As I mentioned earlier, we have a very large Latinx and immigrant population. We serve a large proportion of low-income population, and we definitely serve a complex patient population. In PACE, around 27% of our patients are Latinx. Our 89% of PACE patients are dual eligible, 11% are mass health only. So you can see that we can serve population that is either dual eligible or only from Medicaid agencies. And about the complexity of the patients, which Jim can talk more later, over 50% have 3+ comorbidities. And the top comorbidities includes kidney failure, smoking, obesity, diabetes, coronary artery disease, and COPD. So, very complex. Knowing that there is more resources that you can see that Adriel shared with you on the slides, on the previous slides, about the details of the PACE. I wanted to share here a little bit about for participants who are eligible. And in order to enroll, they need to be 55 years of age or older. They need assistance with 2 or more activities of daily living and skilled nursing need. They need to be safe living in the community with PACE services. They need to agree to receive services exclusively within the PACE network, and that comes along, with the fact that we are also health insurance. And they need to live in the communities that we serve, which are listed here in our areas. Okay, so I'm going to turn it over for Jim to talk more about the features and benefits of neighborhood PACE for all the others. Thank you.
That I'm being seen and heard. Okay, it's working okay. Well, I'm delighted to be here to speak to any audience there is about the joys and impact of PACE. I haven't been a part of it for so long. Some of which I say will intersect with comments by Andreina, so forgive me for any duplication, but I think it's helpful to provide sort of a construct for its place within the larger delivery of healthcare services in the U.S., traditional services. PACE's origins, which were from really the Unlock Senior Health Services organization in San Francisco back in the 70s, originated from an actual need that the Chinese community in San Francisco had identified regarding persons, family members, who all too often had become frail and needed to move on to nursing home care and needed to go to distant places far from San Francisco because of an inability to provide that service in San Francisco. They enlisted someone to help them to really find nursing homes, and having failed that, settled on a day hospital model that incorporated community-based care and gradually over the years bundled in a variety of supportive services and medical services that demonstrated a rather impressive reduction in the need for nursing home care, and tweaked the interest of the state of California at that time. And then beyond that, the Robert Wood Johnson Foundation and Medicare in terms of its expansion. And what that concept was over time from 71 through 86 was that if you took the typical payers of healthcare services in the US, which are of course Medicare, public payers, Medicare and Medicaid, and you fused them and you gave the providers of care the flexibility and the permissibility to innovate in terms of delivery without artificial barriers that typically exist in fee-for-service and traditional care, then that may have some benefits in terms of providing patient-specific, patient-centered, shared decision-making around their outcomes. And that, a long story short, it was demonstrated in actuarial studies and in demonstration studies early on. It went on to spawn the PACE model of a demonstration project that we were first part of in 1990. And after several years after that, it became a piece of the actual CMS product line, if you will, ESRD, hospice, PACE. So we're an official part of Medicare with state sponsors. And that concept remains the same today, that in these localities across the United States that may differ in their makeup, although many are multi-ethnic, they may differ. Typically, the model itself wanted to demonstrate that it was independent of any sort of cultural phenomenon in Chinatown in terms of families and others, taking care of their older relatives, that it was something that could be demonstrated across multiple populations and has been repeatedly shown to be so. That it could be shown then to be done with highly coordinated care, of course, care that is less than the typical cost for that population under traditional care, and preserve community-based living. And so that's where we are today. I believe it's roughly from 65 to 80,000 or so, to give you a perspective on scope, 80,000 people in the US receiving PACE care in the 38 of 9 states. They estimate there's 2.5 million people who are dual eligibles in this, who are frail in the US, and perhaps as high as 10 million of folks of other economic backgrounds. That, I mean, the notion for PACE is that in scaling, it should be great for everyone, no matter their economic background. And having actually a personal experience with my own parent, I wished for a PACE program where she lives, and she would not typically be eligible even right now from her own economic background. So we in East Boston were one of the first 4. We've, as Andreina pointed out, have had a number of, expanded to a number of centers. We early on in our history created close linkages with housing that I'll talk about at length. We've always believed in East Boston. I think there have been national forums about the linkages that really should be explored for PACE services and housing. Housing is an integral part of how frail older adults remain in the community with adaptations in their housing and in their services. So our care, like other PACE programs, wants to be easy accessible. We have transportation that we own ourselves, but also contract out for. These are typically populations that wouldn't be able to get to an ambulatory care practice. The ride can be inaccessible. Their own, certainly personal circumstances can make that difficult as well. So transportation is a key feature. Enhancing their quality of life by bringing them to centers. So what might distinguish it from other coordinated care models for older adults is that, at least for a cohort, the ability to come to a setting for which they probably have never been to for a number of years. Some have been probably holed up in 3-deckers and being cared for by their younger children and everything, but really not being among peers. So there's a certain, I think, aspect of the therapeutics of the model that's achieved solely through being with peers in centers. Not for everyone in PACE, but there's certainly a subset for whom it's really quite magical. To promote their autonomy and dignity, certainly our participants will get to the details of how they express their choices and how we strive to accommodate those choices in their goals for their future. Preserves and supports the family unit. Many of the persons, certainly, as they become more frail, they become more dependent on their children and relatives for supports. Those individuals need to work as well. Respite that comes from being in PACE, both in the centers and otherwise, is of obviously enormous assistance to family units. Maximizing physical, cognitive, social functioning. Again, the presence of the centers, being among peers, physical therapy and exercise opportunities for those who wouldn't normally have that in centers that individuals can be transported to. Next slide. It's done by a team. So the other sort of central concept of PACE is that in typical traditional care, there's obviously contracting with multiple agencies that provide multiple different things, whether they're local ASAPs, individual psychiatric practices, physical therapy services when people have post-stroke or post-fracture. Well, a PACE model brings all of those folks in-house. They're all in the same co-located practices. They can easily interface with each other in terms of shared decision-making with participants and also provision of services. So the typical PACE interdisciplinary team has social workers, many, several, but primary care providers, physical therapists, personal care assistants, nursing, occupational therapy, transportation, dietitian, home care coordinators, the center manager, who's responsible really for the central operations of that entire interdisciplinary team, and the participants certainly at the center of that group. Oh, next slide, sorry. IDT, the PACE model relies on timed assessment, irrespective of events or frailty or episodic illness, that every participant, regardless of their stability, at 6-month intervals, is fully assessed by core members of the team, reflecting back on the previous 6 months and changes that may have occurred and need to be made, and looking ahead to what may be necessary over the next 6 months, anticipating change. It's done through a care plan, an interdisciplinary care plan, not a medical care plan, that examines their needs through an interdisciplinary lens and through their focused goals. Next slide. So this is sort of redundant. It provides comprehensive coordinated services. I'll get into specifics in a little bit. Developing an individualized care plan and providing services that are global in scope, not merely medical, but which are intended to address all of the frail older adults' needs. Next slide. Again, in our marketing to our participants, we place them in the center. These are from our brochures. We want to highlight for them that there are supportive services that you can see in the listing. I guess one of the things I could also mention is for managed care for the elderly in general, but also is that those services that are typically not funded or not as fully funded as for older adults, like dental care, podiatry care, eyeglasses, hearing aids, all of those most certainly are all covered under PACE. Basically, the fusion of the two funding resources provides provision for everything that would be a healthcare and social service need, including getting to those locations, everything from what we describe as from ICU care, chronic hospital care if necessary for specific conditions, down to the meals that we provide in our centers. Okay, next slide. It's a fairly extensive operation. We're at nearly 800. There are PACE programs in Massachusetts that are at anywhere from 1,000 to 1,200. There are PACE programs across the US, nearly 3,000 or more. The operations of a PACE program are daunting. They've been more complicated by COVID. They've been more complicated by staffing challenge. But in the ideal setting in a PACE organization, you try to do as much yourself as you can, but there is much contracting and partnerships that exist as well across other traditional partners. For example, just in this 1 year interval that is described in the top line, we had 71,283 one-way trips completed. The van rides become small communities. There are folks that every day intersect with their peers in vans as well as the centers. And right now we're of a size that we actually have a separate staff merely for the referrals to all the various specialty care that's necessary for all of these 800 members. And last year, nearly 11,200 conducted. We at East Boston, this isn't necessarily the case for all PACE programs, but we've many years ago brought our meal services in-house. So they're produced by our own staff for our neighborhood PACE. We've served 124,000 meals. Those are not merely the meals at the centers when folks who come into the center, but also a large volume of home delivered meals. Next slide. It is a whole operations to, again, as Andreina mentioned, we are both insurer and provider. So once the monthly capitation payments are coming into a PACE program from CMS and from Mass Health, we then are the payer of all the things that we require of others. Again, the hospitals, nursing facilities, home health agencies that we partner with, contracts need to be established with them. We are vicariously responsible for their quality. CMS holds us to a standard to, so we commonly are reevaluating contracts for those who provide services to us. And we have wonderful partnerships with a whole array that span from assisted living facilities, nursing facilities, transportation, private dentistry over the years. We process those claims. Those claims require referrals that's established through we have an electronic medical record, EPIC, that we use, but it's integrated with the piece that produces referrals for consultant visits and for many other things, DME, durable medical equipment, and many other items. And for entry into the plan, we coordinate with our own state agency here in Massachusetts and others do in their states regarding the eligibility for persons in Massachusetts for PACE, as Andreina described, requiring at least 2+ needs from activities of daily living, and also being in the vicinity of Mass Health level, although those that are eligible for PACE need not meet strict income levels for Mass Health. They are waived in a sense that they can spend down to that Mass Health level through income because of their frailty. Next slide. PACE was actually lauded during the terrible pandemic that occurred for its ability for its populations to make them as safe as was reasonably achievable, and with such a terrible pandemic. We've received, all PACE programs provided high vaccination rates in the first 2 boosters, certainly, and now as we continue into the additional booster required for updated status. So it was obviously a priority during a time when those were first released in that December and into the next year. It was a very high priority for PACE programs to establish full vaccination for its members. Thank you.
Thank you, Jim. I'm going to talk now next about the growth and special projects that we have in Neighborhood PACE. If you want to go to the next slide, Ariel. Okay, so we have been growing the PACE sensors in our communities, and we continue to grow. Right now, our membership is around 788. The majority of our patients reside in the East Boston, Revere, Chelsea, and Winthrop areas, which are supported by our existing PACE sites. But as I mentioned earlier, we are with the opening of our new Everett ACS. We have located that ACS strategically in an affordable housing building in a community where East Boston Neighborhood Health Center has less penetration. So we are actively working in growing the census in that area of the surrounding neighborhoods. We have been growing. We do a satisfaction survey for our participants on a yearly basis. And we have been happily seeing an increase on those survey results over the years. So right now we are, and I don't have my glasses on, but I think it was a 95% that it's over the satisfaction on our patient population, which is a quality measure for us. So we're very proud of that increase. In terms of the program innovation and investments, for the last few years, we have been being very actively. We did some network expansion on 2020 with the MGH, Mass General Hospital in Boston. We did some important renovation in 2 of our PACE buildings. On 2021, we started Hospital at Home initiative, patient experience program. We did a scheduling module in Epic, and a home care module, mobile documentation in Epic as well. For 2022, we went live with an Epic Care plan tool, which was a big IT initiative for us. We started the Addison renovations. We started a safety device lifeline for our own staff. We renovated. We did some changes into an internal call center. We centralized it. It was previously deployed over the several centers that we have, but right now it's all centralized. We did some other renovations at Winthrop. We did some kitchen renovations, and we had the construction of the ACS. And for this year, at Everett, I'm sorry. And for this year, we are planning to launch telemonitoring. As you all know, with the pandemic hit us hard, and we had to kind of reinvent how we would serve our patients, and we learned a lot, and telemonitoring was one of the initiatives that we are going to be launching to support that, and also the staff shortages. I saw that there was a question about that. We're not different than any other healthcare organization, I believe, across the country. We do have been having staff shortages as well, and the telemonitoring, we hope that is going to help leverage IT to better care for our patients. We are working very hard to do the census growth in the Everett and catchment area, as I mentioned earlier. And we are expanding meal services in the community with this, leveraging the services that we currently have in the kitchen. As Jim mentioned, we have a very active meals program for our elderly in the community. So I guess that's all I have for now. Thank you so much.
Wonderful. Thank you so much, Andreina and Dr. Padula. What I'm going to do, I think, for the sake of time, we have a couple of discussion questions that are in the slides, and we will come back to them. I think that both of you have kind of partially touched on all of them already, but we can dive back in if we have time. And I know we had a workforce question that's been partially answered, so we'll circle back to all of that. So I'm going to actually go past these questions so we can get a quick update from the National Association of Community Health Centers. We have Jason here with us, who you can see came on camera. I'm going to read Jason's bio quickly and then let him give any other additional context, again, for those folks who are saying, oh, I really want to learn more about next steps, implementation. I'm curious about what this might look like in my setting. Jason's a great point of contact for that. So quickly, Jason's bio. Jason Pat Nash has been with NCECE since 1999, when he started as an intern. For nearly 12 years after that, he grew in his responsibilities and role with NCECE AmeriCorps project. The program became the nation's largest national service program based in healthcare, and he led coalitions to advocate for additional resources towards national service. In 2012, he transitioned to a new role in development and fundraising, where he began working with NCECE divisions to increase resources and partnerships. Jason has helped to navigate successful funding from foundations like the Robert Wood Johnson Foundation, the Retirement Research Foundation, and the Open Society Foundation. Along with several federal agencies, corporate partners, has introduced new partnerships with innovators and startups from the health technology sector, culminating to more than $100 million over his time with NAC. He's served as NAC's lead liaison for the field and partners responding to natural disasters across the country. He's helped to strengthen partnerships for NAC and health centers with national relief organizations. And since the emergence of COVID-19, he's led cross-divisional meetings and projects to enhance resources for health centers fighting the pandemic. He's also been appointed to serve on NAC's organizational development team, and has been instrumental in the launch and sustainability of NAC's new Center for Community Health Innovation. So lots of things you've been doing, Jason, but tell us a little bit more, anything around PACE at CHCs, anything else folks can look forward to hearing about.
Sure, and East Boston team really did a great job covering a lot of this. And Ariel, your opening slides were really teed up a lot of great information that's out there provided by the PACE at CHCs initiative, which NAC has been a partner of with both Capital Link and the National PACE Association. also with the Galway group for several years now, all great leaders in the PACE space. Where we started this project even a few years ago, we were still at under 10 health centers nationwide with PACE programs. And we've seen that number double over the last several years. We've seen growth in California, Massachusetts, Michigan is exploring. We've seen state legislatures like Illinois and Maryland actually making it easier for community health centers to explore PACE. Illinois was one of the last, what I'll call larger states that had not had PACE programs at all in the state. And now they have, I believe, 2 to 3 health centers that are exploring ways to open a PACE program in the next couple of years. And we're also seeing in Maryland an emergence from one health system really having most of the market to opening up for new PACE programs in the state and also in Washington, D.C. So I think it's an exciting time for health centers who may be exploring PACE for their growing populations of aging patients. One of the things, and you shared this in one of your earlier slides on the growth in the aging population of health centers, and during COVID, this was the only population that grew in 2020 with 600,000 new patients that year, over 55 plus. So I think a lot of health centers, as they realize whether they are PACE ready to take on the full 18 to 24 month planning process to lead into it, or they're looking at new partnerships and community-based partnerships. And that's, I'm glad that you pointed out items on the Health Center Resource Clearinghouse, because if you simply type PACE into that website, you'll come up with several resources, including a couple webinars enacted in 2021, focus on the community-based provided models for PACE, where there may be a role for health centers to provide the primary care, maybe some of the wraparound services, but not necessarily be the full lead on the project. And that's something I hope health centers think about. The one other thing I'll say, National PACE Association offers a great membership opportunity for those health centers maybe exploring PACE, and it's almost kind of an introductory to PACE membership that they can have, I believe, for 1 to 2 years. And I would encourage health centers to explore with them because it really gives an access to a lot of the NPA resources. And then the last thing is NAC's Subcommittee on Healthy Aging, which reports into the Health Policy Committee, meets twice a year. And that committee has really, I can say, has amped up the discussion around PACE in each of its subcommittee meetings, both at the Policy and Issues Forum and NAC's Community Health Institute. So if your health center is currently involved with PACE and a member in NAC, it could be an area to think about having staff join this or any leaders join this subcommittee. And I'm happy to talk to folks more about this. I'm happy to take part in the Q&A to be helpful. So thank you, Ariel and Dr. Jim and Adriana, for really covering a lot of the great points already.
Awesome. Thank you, Jason. And I know there's a question in the Q&A box around technical assistance. And I think you answered that, Jason, where there's, we mentioned PACE at CHCs at the beginning of this, that there's this collaborative group, but exactly, if you're going onto the clearinghouse and you're typing in PACE, there's several archived webinars and downloadable publications that are around PACE implementation, again, considerations for your organization, what other partners you may have in your area to not necessarily go it alone. Some good resources there. And if you're looking for additional TA, know that Capital Link and the Galway group and others may be able to meet with you one-on-one and kind of suss out additional needs there. So we have a few minutes left. We have a couple more questions from the Q&A box that I'm going to prioritize over some of our pre-done questions, just because it's so great to hear from folks. I want to go back to a question that was earlier in the Q&A, and I think again has partially been addressed. I know, Andreina, you said, we're not dissimilar to other healthcare organizations. There have been some workforce concerns, and certainly we've seen a lot of burnout across the board over the past few years. But the broader question was just kind of about the range of staff by clinical training and non-health staff, turnover pay, their own health, wellness, burnout. I'm asking also about our community health workers or CHWs involved in your PACE and kind of what can we do to grow the talent pipeline and honor them for the critical role they play and grow the staff we need in the future? So that's a big question, obviously, and certainly we're all exploring that, but anything either of you from Neighborhood PACE want to say to that question specifically?
Yes, well, definitely be a very big concern, I believe, for healthcare in general, the staff shortages and burnout and everything that it's a big conversation right now. We have had this conversation at Mass PACE locally in Massachusetts. We have this conversation at National PACE Association. Specifically for us at Neighborhood PACE, we have done several things to try to cope with the staff shortages. Definitely giving, for example, referral bonus to our workforce, right? To try to engage people that they know, to bring them to our workforce, to our staff. We have partnered with local organizations, specifically at East Boston, to grow talent within the healthcare space early on since high school. Try to engage with local organizations that work in preparing workforce to very early on. There are a few initiatives around that, specifically at the East Boston area, as I said before. We have been doing a lot of advertising, and we are planning now to launch a big advertising campaign just to be able to have more talent coming over. Leverage technology, as I said, to optimize operations is a big, it's a big initiative that we are doing with the monitoring, home health monitoring. And I don't know, Jim, any other thing that I'm leaving off the table that we have done? We have been very close. Yeah.
There's been a dialogue nationally as well in terms of PACE and locally that, and for anybody in healthcare, but certainly is that it can't, although it's not a short-term solution, I think the initiatives that look toward attracting individuals when they're thinking almost at the level of what am I want to do when I grow up? I mean, it has to go back really early on before sort of paths are already well in place. I think investment really needs to be made in that in people in many things, in many different things, whether they're, clerical staff for a PACE center. It's a unique job. It's an extraordinarily unique job that can be quite rewarding. I mean, it's really, there are probably unreached persons, and there needs to be a way to reach them through, the thing that people describe is, where does everybody get their sort of first looks at what they want to look at for a job? Is it all in Indeed? Are there places where they look in their education and in certificate programs? Where do they first even get that inkling and to get into those places?
Right. Yeah. And
yeah, just for the sake of time, I hate to cut anyone off. It's so interesting to hear everyone's perspectives on these. We're almost through. I want to just put a plug in. If you have to leave early, a survey is going to pop up. We'd love to hear from you. And I see a few folks putting different emails in the chat. But there was a quick question around using Epic. Andreina, you said yes, we do. Question around did you have to build out specific workflows for PACE in Epic? And I know it's a larger question. I think there's another Epic question in the Q&A box, but within our last minute or two, is there anything Epic related that either of you want to mention?
For us, you're talking about for us?
Yes, for Neighborhood PACE. Yep.
Yeah, we there's a growing interest, in the U.S. for some group of customers. The barrier with Epic always is that it's a fairly expensive EMR that usually leads a larger parent or everything. Their PACE programs range from standalone PACE programs, of course, to ones that are part of large health systems, and so there's variable ability to acquire it. It has sort of its maintenance. It's a highly modifiable product, which we've always been very happy with. We've been with it for over 20 years. We developed our own care plan in it, and now we've incorporated they caught up to us, I guess, to home health anyway, in terms of developing integrated care plans. So we think it's a very worthwhile product. We know it has competitors that are maybe more affordable, perhaps as well, but but we certainly are pleased, always been pleased with Epic.
Well, I know that, this is a topic that certainly we could spend a lot more time on a lot of these different elements, and we've mentioned that there are other TA opportunities available for thinking about implementation or organizational self-assessment. So we do hope that you all take a look at the clearinghouse, you connect with whether it's NAC or PACE CHCs in general. We thank all of our panelists so much for their time and expertise today. We thank everyone who's able to attend live or watch the recording. We hope you found this useful. I think there may be more questions coming out of this session, which is good. I hope that you're able to connect with resources, to talk with others in your organization and your communities, because this is a really fantastic way to meet the needs of a population that is aging. And we have a really great opportunity to play a role in that. So thank you again for your time. We hope to see you back soon at a future learning opportunity. Have a wonderful rest of your day. Take care.
Thank you, Nell, very much.
Yeah.